So I'm going to talk about Ebstein's malformation. So let's just think about Willem Ebstein. Willem Ebstein was a physician in Germany. He worked in Berlin and Breslau, and finally landed up in Göttingen as the professor of medicine. He wrote over 300 papers in an era in the 1800s where publish or perish was not the important issue. And so of these papers, he largely concentrated on hematological abnormalities. The Pell-Ebstein fever phenomenon is named after him. There is an Ebstein kidney, and of course there's this other disease that we're going to talk about, which occurred actually when a young 19-year-old bricklayer, Joseph Presser, arrived in his unit in atrial tachycardia, and he put him in a bed, and over the course of a few days, Joseph died. And as Ebstein was a Renaissance man, he also did the autopsy. Now, this was in 1888, and in those days, photography was not what it's now, no smartphones to quickly take a picture of the autopsy. So he called an etcher in, and the etcher made these sketches of the Ebstein's malformation, which shows everything that we need to know about the abnormality. There's a big fossa ovalis. The septal leaflet of the tricuspid valve is vestigial. The anterior leaflet is large and sail-like, and the inferior or mural leaflet is fused with the anterior leaflet. There is an area of atrialized right ventricle, and when you turn the heart out and you look at the pulmonary valve, you can see the so-called keyhole orifice of the tricuspid valve with these hyphenated attachments of these abnormal tendinous cords. So from this, and one paper that he wrote out of 300, he has become famous for all times. So here is, unfortunately, a patient of mine that we decided to operate on and close the atrial septal defect. So we've opened the atrium now, and we're looking down at the atrioventricular valve and the right ventricle. And what I've done here is I've highlighted the position in orange of the atrioventricular valve in the normal. And you can see from the blue that the anterior leaflet of the tricuspid valve, which is this, is normally attached. It is quite abnormal in its character. We'll get to that just now. The septal leaflet is not attached to the annulus, but is attached to the actual septum, and the point of maximum displacement of the valve is between the mural leaflet or inferior leaflet. It is not a posterior leaflet, and the septal leaflet of the tricuspid valve. And so it doesn't look anything like a normal tricuspid valve. Now, the etiology of this condition is one of a process of non-delamination. So anyway, what happens in Ebstein's malformation is that the valve develops on the wall of this spongified fetal ventricle from Dr. Netter's book. Here is an 8-day-old mouse embryo, 1 millimeter in length, showing this non-delamination and spongy myocardium, as you see here. And what happens in the course of this, in the normality, is that the leaflet becomes more and more delaminated by a process of apoptosis which occurs underneath this valve. And here is a human embryo of the 16 to 18 Carnegie stages, showing the septal leaflet of the tricuspid valve and the anterior leaflet attached with this underlying process of spongiform appearance with apoptosis of this, which brings the tricuspid valve to its normal annular position. So I like to think of Ebstein's in terms of a mnemonic, and I've developed this little thing that helps me remember what's happening in Ebstein's anomaly. It's called the dozen Ds. If you can think of another one, if you'll please approach me during the course of this lecture and let me know so that I can add them to the dozen Ds, maybe make it a baker's dozen. So there's displacement of the proximal attachment of the valve. The valve is dysplastic. The attachments distally of the valve, as you've seen already, are abnormal. The myocardium is dysplastic, and as Dr. Cuneo mentioned, we have Doppler evidence of dysfunction of this myocardium, and the myocardium dysplasia is not only in the ventricles, but is also extended into the atrium, particularly the right atrium. There's no D in arrhythmia, so I've made them dysrhythmias. The right heart chambers are dilated. There is dysfunction of both ventricles, as Dr. Cuneo mentioned, both systolic and diastolic. As we've seen, the ductus is a problem, creating what they call the circular shunt, or as I like to call it, the circle of death. And deformity of the right ventricular outflow tract and pulmonary valve. Other defects, such as ventricular septal defects and spongy myocardium. And of course, the final D for all of us, including patients with Ebstein's, is death. So just let's look at what Ebstein's really looks like. And this is a picture I've got from Professor Anderson. Here is the normally attached anterior leaflet of the mitral valve. But you can see in this valve leaflet that, in fact, you can see the tendinous cords going through it. There's these little wart-like projections on the valve. And this here is the septal leaflet of the tricuspid valve, which is vestigial and verrucous in its nature and displaced from the annulus of the valve. Here's a normal right ventricle as we would look at it. And this is a right ventricle in Ebstein's malformation viewed from the right side. And instead of a beautiful little tricuspid valve like this, you see this large sail-like sheet of tissue, mere excuse for a really normal anterior leaflet of the mitral valve. And here you can see the tendinous cords that come through this, attaching this valve leaflet, and that there are entrances into the apex of the ventricle and also towards the outflow of the ventricle. Now, the worst kind of Ebstein's malformation is this kind, where this valve leaflet actually develops, but it fails to delaminate entirely, and so that it blocks the outlet of the pulmonary artery from the rest of the ventricle. And that's called Ebstein's with pulmonary atresia. Okay, how does this develop? Well, as Dr. Abu Ahmad had mentioned, we really don't look at these abnormalities in the course of the development in the embryonic stage. We look at them initially in the fetal stage. And this is a 19-week fetus from my institution, where already the well-marked features of Ebstein's are noted. There is a dysplasia of the valve, which is thickened and enlarged. The atrium is extremely large. There's tricuspid regurgitation. And we divide the ventricle into the atrialized ventricle, this piece, and the functional right ventricle here. If we turn this fetus over and look at it in its so-called long axis with the vertebral column behind here, we can see the aortic arch, and I'll let it play for you. And here is the aortic arch, and here already at 19 weeks is retrograde ductus flow. So there's tricuspid regurgitation already setting up this circular shunt that Dr. Cuneo mentioned, with all of the blood flow coming back and going through an ineffective pulmonary valve, which we'll discuss, and then back into the atrium, across the atrial septum, and back into the left ventricle, exactly the reverse way of the way it was shunt. Now, if we align the probe exactly at this point, we get a short axis view. We see the descending aorta, we see the pulmonary valve here, and we see the right pulmonary artery flow, but the flow coming into this pulmonary artery is coming entirely to the valve here, and then bouncing off the valve and going back into the artery. So the ductus shunt here is left to right originally. And this particular fetus, when a valve is held in the closed position, it develops little adhesions across it, and it can become atretic, which is what happened in this patient. It can either become atretic or it can become a poor valve and become dysfunctional. Now, in 1989, we established this technique for looking at the ventricle using the atrialized right ventricle against the rest of the chambers to establish a ratio. And when the ratio reached 1:1, we thought that that was a poor prognostic sign. And we published that some time ago. Dr. David Sellermeyer, actually I found out is a relative of mine living in Australia but working at that time in London with Dr. John Dinfield, developed a ratio of indexes of this particular ratio of the atrialized right ventricle and the atrium against the rest of the cardiac chambers in a 4-chamber view. Okay, and we'll come to that in a moment. But let me just show you sometimes that you can see this huge atrialized right ventricle here in a patient who has got, this is a Carnegie stage 16 embryo, human embryo, showing this non-compacted left and right ventricle and already with not yet the delamination of the tricuspid valve. And if this condition persists, as it does in 15% of Ebstein's malformations, we have spongy myocardium associated with Ebstein's malformation and a huge atrial septal aneurysm because of non-function of the right side of the heart, with massive tricuspid regurgitation from the very apically displaced ventricle. So back to the grades. We have the 4 grades that was established by Dr. Sellermeyer, showing very severe displacement of the valve with a big atrialized right ventricle. And when this was greater than 1.5 to 1, the mortality was found to be 100%. Lesser degrees of mortality were found as the ratio diminished, with a mortality of only 44% when it was 1. When it was 0.5 to 0.9, only a 10% mortality, and under 0.5, no deaths were recorded. Now that has been blurred a little bit, but this is what the follow-up looks like in terms of this afterbirth from Sellermeyer's later paper, showing again this, as the degrees get worse, the survivability in terms of days after birth becomes really quite substantially clearer based on the grade. Now, I think that this has changed a little bit because our surgeons have become much more skillful at repairing some of these patients. And another surgeon who has also been very important in terms of this is the French surgeon Carpentier, Alain Carpentier, who developed a degree of drawings which showed mild, moderate, severe, and terrible Ebstein's malformation. As this occurred, he showed the relative displacement. And as you see from looking at these pictures, there is no septal leaflet in his pictures. What we're looking at is anterior leaflet and the mural or inferior leaflet of the tricuspid valve, which also becomes progressively displaced. And I think this is one of the things that I have to bear as a cross, because I said the septal leaflet was abnormal in 1977 in Ebstein's malformation, but we forgot about the fact that the mural leaflet is displaced. And I think that's very important that we look at it as echocardiographers, because it gives us an important assessment of the severity of the Ebstein's disease. Now, we talked a little bit about the circle of death, or the circular mode. And here are 2 old-fashioned M modes. I still love M mode for looking at valve motion. It's much more precise than Doppler ultrasound. And this is a patient at 20 weeks that you see here with beautiful opening and closure of the pulmonary valve. And this is, the baby died at 38 weeks of gestation. This is the 36-week echo on this patient's pulmonary valve. So you can see that the pulmonary valve has absolutely no motion, with a little shock related to the motion of the heart. And this is the specimen showing the sail-like anterior leaflet, the verrucous displaced septal leaflet, and the inferior leaflet, which is also displaced. But a probe has been placed in the pulmonary valve through the main pulmonary artery, and you can see that this pulmonary valve is totally underdeveloped. So that what happened here was, as the ductus flow kept this pulmonary valve in the closed position, because there was no effective forward flow from, or progressive lack of forward flow across this tricuspid valve, the pulmonary valve became atretic, or they develop insufficiency and the circle of death. And so let me just point out again that the mural or inferior leaflet is displaced, and we can really identify this on fetal ultrasounds quite easily. And the way to do it is to look where the inferior vena cava comes into the right ventricle in sagittal plane imaging, and you'll see where the Eustachian valve is, which is here, and that marks the place where the tricuspid valve, the inferior leaflet, should be. And you can see the inferior leaflet is quite markedly displaced over here. And this was something that we first identified in the fetus. Here's the inferior cava. There's the displaced septal leaflet. This is atrialized right ventricle. This is functional right ventricle. There's a thickened abnormal pulmonary valve with a small annulus and a small pulmonary artery. And I have another picture to show you those features as well. Here's septum primum. Here's the tricuspid valve, which should be over here. So the mural leaflet, as we look at it in short axis or sagittal cut straight down the body, makes it easy to recognize what's going on. And you can see, in addition, in this patient, that the ductus arteriosus is coming off the descending aorta and jetting towards the pulmonary valve, and associated with pulmonary insufficiency, and just off the screen, tricuspid insufficiency as well, providing the circle of death, which is a very poor prognostic finding. So here's the tricuspid regurgitation, and here's the pulmonary regurgitation here, this little red flame. So this is what my medical students called for me the circle of death. So just let's look once again at that circle of death. Here's the pulmonary valve with insufficiency, and the tricuspid valve with insufficiency going the wrong way. And this is a diagram by another surgeon, Dr. Christian Schreiber, who passed away. And what he looked at is mild, moderate, and severe Ebstein's malformations, showing in the sagittal plane how you can quantify the severity of this obstruction. And here you can see the displacement of this tricuspid valve leaflet. This is turned round in another position. So here's inferior vena cava, here's the Eustachian valve, and here's the mural leaflet of the tricuspid valve, which should be in this position over here. And the tricuspid regurgitation then is directed not into the atrium, but down into the atrialized right ventricle, and the jet direction comes directly towards your transducer. So these are fetal examples, and you can see this also postnatally as well. Now, back to this other patient that we talked about. This is a patient that came to us that had severe Ebstein's, as I'd mentioned. But we also noted that there was a spongiform nature of this myocardium, which is a topic of another talk that I'll be giving later on this very topic. But you can see here the spongy myocardium here, which is associated in this case with poor left ventricular function. And this is in actual fact that other part of the Ebstein's disease that we haven't considered, which is the actual myocardial abnormality, the cardiomyopathy that is part of Ebstein's malformation. And because of this poor ejection fraction, we listed this patient for a heart transplant prenatally and got this patient transplanted on the second day of life. But before that, we got in quickly and did an echocardiogram, and you can see the lousy left ventricular function together with the spongy myocardium as defined here by this multiple layers of ejection going down towards the epicardial surface of the ventricle. Now, Dr. Bettina Cuneo also talked about hydrops fetalis in these patients. And you can see here the compression that occurs and the problems that occur in the lungs as well. The thorax is a very bad landlord, because the amount of space you occupy determines how much rent you pay. So if the heart occupies a lot, you have to make the lungs occupy less. And cardiomegaly is obviously an important feature of Ebstein's malformation. But in addition to that, the pericardial effusions that develop and the pleural effusions and the rest of the hydropic picture become very important in determining success of the patient. So those with hydrops, as you can see here, obviously have a much worse prognosis. And the physiology of this is very important. Here is the so-called Starling equation, which actually, JV, I'm not going to go through the equation, talks about the hydrostatic and the oncotic relationships across the ventricle, across the capillary, I beg your pardon. So that if the hydrostatic pressure increases relative to what occurs in the tissue, a fluid will flow out from the capillary into the interstitium. And the fetus is actually much better capable of handling lymphatic fluid, which comes out of the interstitial fluid here, than the human. In fact, the amount of lymphatic drainage in the fetus is 5 times as much as postnatal flow in the human. So, of course, they're much more critical, and one of the most critical features in the normal situation is the amount of albumin. So if there's hyperalbuminemia, this can increase the transudative nature of fluid. And also if you increase the hydraulic pressure by tricuspid regurg or chronic venous regurgitation, this sets up also the situation of hydrops in the fetus. And of course, remember fetal albumin, which is a significant feature of the withdrawing the oncotic withdrawal is much lower. So let's just summarize what I've said about Ebstein's. We've seen the bad prognosis that Dr. Cuneo mentioned. The tricuspid regurg is what does them in. That's a Cockney slang, if you'll forgive me. The tricuspid valvular insufficiency leads to a lack of forward flow in the pulmonary artery, and the flow in the pulmonary arteries increases during gestation as the ductus sees the systemic pressure from the aorta. The ductus contribution to flow into the pulmonary arteries becomes partial or complete. As the blood pressure rises during gestation, the force of contraction of the right ventricle also has to increase, and the normal fetus can do this. But in Ebstein's malformation, it fails. And the pulmonary valve is either held in the closed position or has its development interfered with, and it may become regurgitant, and in fact the whole right ventricular outflow tract may become hypoplastic. So the anatomic and developmental abnormalities of the tricuspid valve lead to right atrial enlargement. And of course, if you look at the right atrium morphologically, the right atrium in Ebstein's malformation is abnormal. You can read a newspaper through the wall of the right atrium in some of these fetuses. It's so thin. Okay? So we know that, of course, there's a morphological basis for the functional abnormalities that Dr. Cuneo mentioned in her lecture. The dilation of the right atrium interferes with right atrial function, and then, as opposed to the postnatal circulation where the right atrial hypertrophy develops, it becomes thin and dilated. And the right ventricle also dilates, and its organization of trabeculations and papillary muscle, as well as the function of its myocytes, becomes attenuated, and there's backward failure, which leads to hydrops. So, just before I close, I'd like to mention that Ebstein's malformation has been well described in congenitally corrected transposition. And in this condition, here is a cartoon which I got from the Mayo Clinic. You see the relationship of the mitral valve to the tricuspid valve, and this valve leaflet is adherent to the septum over here, so there's Ebstein's malformation. But this Ebstein's malformation is coming off a right ventricle which is connected to an aorta. Here's the right ventricle connected to an aorta. I'll put these in motion to show you. Here's the right ventricle, and there's the aortic valve and the aorta coming off the right ventricle. So it's functionally systemic mitral insufficiency. It's not the mitral valve, but it's like mitral insufficiency. And that is a very serious condition, but and its prognosis has not been looked at in Dr. Lindsay Freud's particular study. So you can see here the displacement of the tricuspid valve from the mitral valve. And of course, as Dr. Abou-Ahmad set us up beautifully to understand these issues in his earlier talks today. So this is a different condition. We haven't seen it, but its prognosis is bad. And its prognosis is worse in congenitally corrected transposition, of which I see there is a talk in the symposium, because there's almost no case of congenitally corrected transposition that has been seen without abnormalities. 2/3 of them have VSDs, 1/3 of them have pulmonary stenosis, 1/3 of them have this tricuspid Ebstein's, and another third have abnormal tricuspid valves. And they get heart block as well in the course of their life in 1/3 of the patients. So I call it the TERD disease, being from Brooklyn myself. Now, Dr. Lindsay Freud has written several papers on this issue, and she's talked about the bad prognosis and the terminations of pregnancy in 6%, demises in 17, 176 live born, of whom 32% died in their limited series. And I think the thing about death in Ebstein's malformation is that we have to look at the postnatal era of this condition, because it depends. If you only look at the first 5 years, obviously you're not going to have as many deaths. But if you look at it over teenage life, there is a substantial decrease. And the predictions of mortality, when you find it in the fetus, are less than 32 weeks, tricuspid valve annular Z-scores, which are large, and pulmonary regurgitation, which sets up the circle of death. So I thank you very much for your attention, and I hope this has been helpful for you.